Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee's screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica, and thank you for the wonderful introduction. I'd like to introduce this session, which is one of our POV sessions. You can increase the impact of health data. So those of you who participated yesterday learned that POV stands for point of view, and we have invited our presenters to just speak about what's on their mind, what they think is important, and what they want us to learn about. So this session has been organized and will be moderated by Alyssa Harris from Vizient, and it is sponsored by HSRI. So I'd like to just give HSRI just a few moments to introduce as to why they wanted to sponsor this session. So I'm going to turn the time over to Leanne Kandura from HSRI.
Human Services Research Institute is a proud sponsor of this session. Dedicated to improving systems that change lives, the team of experts at HSRI is driven by a passion to see all people live fulfilling, healthy lives as empowered, respected members of society. For nearly 50 years, HSRI has been supporting leaders and policymakers and the people they serve by crafting sustainable, community-based, person-driven solutions to complex challenges in health and human services delivery. The HSRI culture is upheld by principles supporting diversity and equity, and the team purposefully acts to understand and mitigate systematic barriers that have impacted communities throughout the U.S. The team works across all fields of health and human services, specializing in aging and disability, behavioral health, child, youth and family, housing and homelessness, intellectual and developmental disabilities, and population health. For over 20 years, HSRI has been at the forefront of health data, partnering with federal and state agencies to design, develop, deploy, and maintain systems that collect comprehensive healthcare data and turn it into useful analysis and user-friendly tools and visualizations. As researchers, the team knows how crucial it is to have clean and valid data. With expertise in methodological standards and measure development, HSRI creates data systems that are robust enough to shape policy and drive progress. We are proud to partner with NATO to make this conference happen and to increase the use of and impact from health data. Please enjoy this session.
Thank you, Leanne, and thank you again to HSRI for sponsoring our session today. At this point, I'd like to bring on stage our moderator, Alyssa Harris from Vizient. So Alyssa, if you could join us. Great, and I'm just going to turn it over to you to handle it from here on out. So thank you.
Sounds good. Thank you, Norm. As Norm mentioned, I'm Alyssa Harris. I am a Senior Research Director at Vizient. I'd like to start off by apologizing for laryngitis. That was a gift for my 2-year-old this week. But I'll be moderating today's POV panel, which is titled, You Can Increase the Impact of Health Data, sponsored by HSRI. If you were able to attend the plenary right before this, there were some great examples of the impact of health data across the U.S. and how individuals are making that data impactful and actionable. So this is a great way to continue with the momentum from that session. We have 3 topics that presenters will cover today. We have Nothing National Works Without Local Implementers from Civitas, How to Make Analytics Better for All Types of Users from Optum, and Empowering Change, Leveraging the Health Waste Calculator for Value, Impact, and Equity from Milliman. This type of session, this POV session, is meant to be very interactive, very conversational for everyone. So I encourage everyone to put questions into the chat as you watch each presenter. We'll cover a few questions after each presenter goes. And then after all 3 presenters have gone, then we'll open it up for a broader Q&A discussion. And so please help make this very collaborative. We want to hear everyone's voice because we know that in research and healthcare, with more voices, we can really amplify and strengthen the work we do and build upon the work of others. So with that, I'd like to turn it over to Civitas.
Work engagement with Civitas Networks for Health. And I have with me today Lisa Bari, who's the CEO of Civitas Networks for Health. And we're going to spend a few minutes talking about the importance of local implementers, local health data-led collaboratives in communities throughout the country as we start to realize important national initiatives.
Yeah, thanks, Jolie. It's great to be here with everyone at NATO's virtual conference. As Jolie mentioned, Lisa Bari, I'm the CEO of Civitas Networks for Health, and Civitas is a national nonprofit member and mission-led organization. As members, we have about 170 of the nation's health information exchanges, emerging health data utilities, data collaboratives, health improvement collaboratives, quality improvement organizations, and importantly, health data organizations and all payer claims databases. And we work collaboratively with NATO as mutual members of each other's organizations. So we're really happy to be here.
Thanks, Lisa. So let's dive into this a little bit. Nothing national works without local implementers. And I think both you and I, in the roles that we play at Civitas and having this opportunity to look across the lay of the land and to work with many communities throughout the country, we really do feel a sense of that you have to have local partners in this work. So let's talk a little bit more about, the importance of all payer claims databases, community care hubs, community information exchanges, health information exchanges, health data utilities, regional health improvement collaboratives, quality improvement organizations, as they come together and they're building connected communities. Why is this so important?
Yeah, I mean, I think, as someone who used to work in the federal government, it's really easy to, when you're a hammer, everything looks like a nail, right? You think, well, I'll just have one big network or one big database. And that just doesn't work because of so many reasons. Our country is massive. Our country, as we all know, has dramatically different, political leadership across the country, in states, in cities, in communities, and accordingly, different laws, especially as it relates to things like health data privacy, how we use health data, what kinds of data we want to use. And so all those things are really important. And if you want to get something done, a big thing at the national level, like you want to achieve, for example, as CMS and Medicare do, they want to achieve, every beneficiary in an accountable care relationship by 2030. You need a ton of local innovators to do that work from the health data side on. You want to bring down the cost of healthcare, for example, you need a ton of local people on the ground doing that work. You need that local data to make sense for them. Some big data set or some big data initiative across the country won't make sense to everybody in local communities.
Yeah, that's so important. And I think that's something that we've talked a lot about. When you think about healthcare affordability, it's really not going to do any good to point the finger in any one direction. We have to sort of collectively say, we've made a huge mess, it's not working. And then we have to be able to come together and hear different voices, different perspectives, hear from providers and payers and patients and purchasers about sort of where their pain points are to then start to decide what we can actually do about it.
Right. Exactly right. And again, the problems are different in different parts of the country. The players are different, right? There's states that have, are dominated by one health system or, one structure of a Medicaid managed care organization or whatever it is. And there are also different situations in terms of competition, number of players, different types of networks that offer more alternatives to seek lower cost care, for example. And you just need to know what's happening at the local level and have those local people at the table to get something done in a particular state or community. You just can't do it with a general approach across the country.
Yeah, absolutely. And fair to say that the complexity just increases and we're seeing expanding use cases. And, I say complexity, but that's not necessarily a bad thing. I think we're also starting to understand the possibility, what we can actually do by bringing sort of these different entities and communities closer together to have more robust health data sets to then actually try to impact the outcomes of care.
Right. And, we've talked before, I think also at a previous NATO conference about the health data utility model and how that intersects with health data organizations in general. Health data utility is an emerging concept of creating a unified data resource, built around kind of existing infrastructure like health information exchanges or other health data organizations. And the idea is that you have a unified data resource, maybe not one organization or one database, but a unified resource with shared governance that looks across different important use cases, whether it's clinical care, whether it's public health, whether it's affordability, whether it's social care, and says, let's not build the same thing 10 or 20 times and have the state or the feds or anybody else pay for it 10 or 20 times. Let's make that sure that governance is really community responsive, community inclusive, and that we're doing things with health data for the benefit of people in those states and local communities, right? And so, we see that evolving and emerging as states and other stakeholders say, well, hang on a second, this hasn't worked out so well when we outsource these decisions about health data to the federal government or to other national entities.
Yeah, and so, in our few minutes we have left, let's dive in. So health AI and thinking about health AI governance, there's real potential when we think about the health data utility model. Why do you think that's so?
Yeah, so of course, anyone who's been alive for the last couple of years has had, especially in healthcare, has seen headline upon headline about health AI, what's going to happen with generative AI in healthcare, how AI is going to revolutionize X, Y, and Z thing. The problem with that, and then the negative side, which we've been hearing about, is of course, how did you train those models using whose data, in which way, and then also the great, massive need to get more data to train more models, especially when you get into areas that are really, really can be really, really dangerous, like applications of AI in healthcare delivery. And so because of this, of course, if you look across the market right now, health systems are already starting to use AI. And their first thing that they heard from the government and other stakeholders, you need to have governance. So they've all started to basically build up their own internal to their health system governance. They have somebody from IT, somebody from patient care, medical doctors, the nurses, administrative, they have a variety of people involved in that. Now, plus that up to the state level, you're seeing real interest in leveraging those emerging health data utilities for AI use cases within states because they already have this governance view, this inclusive community governance view. And so we think that there are lessons that can be learned from that experience around health data governance through health information exchanges, emerging health data utilities, health data organizations, all payer claims databases who've been doing this kind of complex governance work now for decades as it relates to health AI. So we're seeing that start to emerge. As you know, of course, we wrote alongside a couple of colleagues from the Ellis Institute and from Harvard Medical a piece about the role of health data utilities in health AI governance.
Yeah, it does. It seems like such an opportunity to learn from, like you just said, years of experience navigating very complex, laws and paying close attention to privacy, but also inclusive governance, thinking about how we bring patients and providers and others into the mix to really deeply think about this. And I think there's also, particularly with the health information exchanges, but many others as well, they've been for years thinking about data quality, data cleansing, all of that. And so that's so important as we think about it.
Really, really important
Yeah.
for any application of AI in healthcare, right? A lot of people have been very nervous to start with this idea of bringing AI into actual clinical care. People seem to feel more comfortable with the idea of bringing AI into administrative issues in healthcare. But as people who actually work in healthcare know, administrative data is critically important to the quality of care and to the actual downstream delivery of care. So I would say there's no safe application of AI in healthcare without good governance.
Yeah, absolutely. Well, appreciate that. And I think, it just helps to paint the picture of what we're talking about, which is you need to have trusted relationships. You need to have a diversity of perspectives at the table. You need to make sure that people are really coming together on these complex issues. And you do that inside of local communities. And then that can translate. And there are ways that we then can absolutely impact national initiatives and partner in that way. Anything else you want to say before we close out?
No, looking forward to the discussion.
All right, fantastic. Not hearing
Am
you.
I on mute?
Yes.
Okay.
But hear you now. Yes.
Thank you so much. I would say if anyone has any questions, please put them in the chat. But to start off, we've seen kind of that push and pull. So we get a lot of these directives from the federal level that have to be implemented at the local level. Is there a way we can structure national initiatives to better support local implementers? And can you think of any examples where that alignment has been particularly successful?
Yeah, I mean, I like the way you said that about push and pull. I think, it is all about creating a bi-directional exchange of sort of communication, information, education. A big part of what we're doing at Civitas Networks for Health is advocating and educating our national and federal partners about the work that is happening inside of states and regions and communities throughout the entire country to help them better understand the impact of various federally grant funded programs or sort of, in the regulatory environment, those regulations and how that impacts local implementers. But it's also important to be able to translate why certain national priorities are such and try to help, our communities throughout the country better understand decisions that are being made. I think at Civitas, we're definitely fans of ground up versus top down, but there is a balance.
Yeah, definitely. And I think that seems to apply also when you're talking about that governance around AI and governance in general, where there is that ground up. You have a lot of experience in the governance from the ground up, but there also might need to be governance from the top down on AI. So how do you envision a future of governance for AI? Do you think it will again be that push and pull, or how do you envision the future of that?
Yeah, I think it is going to be push and pull. I think at this point, we've opened the floodgates. Like health AI is here at this point. There are many, many different types of applications that people are using currently. And so I do think, yes, we'll continue to see a certain level of federal regulation and oversight, but within states and regions, we are very definitely going to see a need for increased guardrails and support around the different health AI applications. And I think, particularly when we're thinking about the use of algorithms, and as Lisa was speaking to, the types whose data is being used to inform the algorithms, that becomes really critically important. And it's not just any one, sort of group's decision. And that's where the inclusive multi-stakeholder governance structure becomes so important. It's going to be a combination of private, public, patient collaboratives that need to inform the governance as we go further with uses of health AI.
Absolutely. Do you have any, I know you talked about all the quality and health collaboratives that you have going on. Do you have any collaboratives around AI and the uses that people are using to kind of learn off of each other?
Civitas currently is not, we host many different work groups. We are not currently ourselves leading, but I know, there are other national initiatives that certainly are. And Lisa, our CEO, is participating through the National Academy of Medicine in advisory group that I think is, thinking about sort of that quality aspect, the safety of health AI. And there are others, that are also spearheading those efforts. I think it's fair to say that Civitas will be looking much more closely at our members' health AI policies and helping to support, model policy development that would, again, be able to translate across different sort of states and regions in the country.
Great, thank you. I think we're going to continue to see AI everywhere we look in healthcare. So that's great. Thank you so much. If anyone has any other questions for Jolie, please feel free to put them in the chat and we'll come back after the other two presenters. So next up we have James and Samson with Optum.
What we're going to show you today is something that we're very excited about. It's the Analytics Engagement Platform. So we started the Analytics Engagement Platform with a clean sheet of paper, and we wanted to give a roles-based user experience to our customers. So this is something that we see throughout the marketplace is a lot of vendors are doing this as we are. So it's pulling together analytics from existing analytics platforms into a roles-based user experience that puts users first in the experience. So as you can see here, we have a number of roles: data analyst, executive user, financial analyst, health equity analyst, program integrity analyst, etc. And this user experience will change. So it will change to show users what they need to see so they can be most effective at their job. So really gone are the days when we had a list of reports and people had to pick the right report. So as you can see here, we have My Insight. So this really will direct a user to get the information that they need. So at a high level. So you can think of these as maybe ESPN scores, kind of ripped from the headlines. And this is the executive user. So this executive user will see things from all of the divisions over which she has purview. So opioid utilization, TMSIS, case tracking for fraud abuse investigation, opioid utilization. As we progress down through the demo, we also have My Analytics. And what's cool about this is this particular BI tool we're using, you can write natural language processing queries against the data set. So you don't have to have SQL query skills to use this. Also, we have a place for notes and tasks. And we also have an API to X and LinkedIn. So what this does is this enables you to be informed of what's going on in your program, what the governor's doing, other things like that you might be interested in. One other thing that we have is My Learning. So what My Learning does, this provides context-specific learning for your users. So at the executive level, this could be something like ending the Medicaid determination, managing the end of the public health emergency, Medicaid enrollment, and health equity. But for a user who is a data analyst, it could be how to do row-based security. Next, I'm going to show you another thing that we're really excited about, and this is getting to generative AI and what's going on with all the advances and Copilot and other technologies. So this is what we call a tear sheet, and what this does, this tear sheet provides information that has really a rich context around it. So this provides, as you can see, a lot of contextual information here, a lot of actions that people can take. And what we are doing now is we're actually using generative AI to start exploring writing these things so that we can go and use Copilot to start writing this information. So now I'm going to turn it over to Samson, who's going to talk about our experience with maternal health in New Jersey.
Hello, everybody. Optum has been a steady partner with New Jersey Department of Medical Assistance and Health Services, DMAS in short, for the last 2.5 decades. And most recently, with our hybrid cloud strategy, we were able to rapidly contribute on several initiatives geared towards improving quality of care and reducing cost of care. And I'm excited to discuss today one of our most recent initiatives, around maternal care. Before I dive deeper, here is a data point that highlights why maternal health is paramount and an area where a lot of Medicaid agencies and also the federal government is focused on. As per recent CMS estimates, 41% of all U.S. childbirths are covered by Medicaid. I repeat, 41% of all U.S. childbirths are covered by Medicaid. So it's no-brainer measuring performance around maternal health is significant overall, both for Medicaid agencies as well as recipients. In the last couple of years, DMAS and Optum have collaborated on some groundbreaking work in value-based care, specifically in the Medicaid space, to improve outcomes in maternal care. My name is Samson Annamdevula, in my role managing the data warehousing and analytics engagement for New Jersey DMAS. I have principal responsibility ranging from strategy, program, and account management, and finally, delivery operations. Out of the 25 years in the industry, I've spent the last 6+ years specifically involving Medicaid and Medicare analytics. In terms of agenda today, I want to talk about the why and what around value-based care involving maternal health to set the context on this topic, and spend the rest of the time talking about the how by highlighting 5 dashboards and associated analytics that are integral part of this program. So in terms of the why, this initiative was part of the maternal health reforms of Nurture NJ, a statewide legislative campaign with the goal to improve quality of care and reduce racial disparities and expanding continuum of care. Here are the 5 broad levers for improving maternal care. For the sake of time in this presentation, I will skip participation requirements, and we'll look at the financial incentives and provider reports in greater detail in the next few slides. Financial incentives involve shared savings for reducing cost of care and improving quality, higher performance bonus for meeting higher thresholds in improving and reducing cost of care, and finally rewarding providers for taking care of high-risk patients around substance use disorder. Quality of care is measured using 5 metrics. First 2 are around screenings involving depression and gestational diabetes. The third is around delivery mode, and the final 2 are around postpartum and neonatal visits. The cost of care or spend is calculated over several months after the predefined performance period, and the spend is then risk adjusted by averaging across all the births of the participating practice. Now let's look at the how by going over 5 reports. This slide is a snippet of a report that gives a comprehensive view of the provider performance on the 5 quality metrics providers are evaluated by and also qualify for the financial incentives. Clearly highlighting here is their current performance, whether they're meeting the current minimum threshold or exceeding to meet the commendable thresholds. In addition, this report highlights a number of measures they need to improve on in terms of quality for shared savings as well as for high performance bonus. This report snippet illustrates the cost of care for each of the 5 quarters, each of the quarters rather, against the benchmark, and also the average spend against their peers. It also highlights if they're on track to qualify for the shared savings and higher performance bonus. This report snippet is intended to provide provider episode volume, and if the volume exceeds the expectations, and if the volume really meets the expectations of the financial incentives. In terms of the requirement for qualifying, there are 15 episodes at a minimum that provider needs to qualify for. The next 2 slides, and this slide and the next slide, provides a greater detail on the quality of metrics against the benchmark, clearly illustrating current provider performance in yellow in correlation with thresholds around minimum and commendable ranges. In this case, in this slide, for the delivery mode and postpartum visits. And in this next slide, we clearly provide greater detail on depression and gestational diabetes screening with additional context around health disparities by patient race and ethnicity. With that, I'll hand it over for further questions.
Great, thank you. I'll unmute myself this time. But thank you so much, James and Samson. There's a lot of really good information that you're presenting on. First, James, I'll start with you. You presented a tool with a lot of complex information that you really have distilled down into something that is easy to view. And you mentioned that there's a lot of ways that you can really personalize your role. How are you balancing that need for the robust insights with having something that is intuitive and also usable to people who are viewing your dashboards?
And that's a great question, and that is, kind of the balancing act between overwhelming people. Some of our legacy systems would have 80 reports on it, or some of the systems that we've taken over when we're working on these projects, and people didn't know where to go. So we're working with folks that think about how people interact with information. One of the key things that we find is to help them get the information that they want at a summary level, and then they can drill in from there. So, their workflows could be on tablets or on PCs, but just really what we've found through our research is people that use these systems were kind of overwhelmed, and then they ended up just phoning a friend and saying, "Would you please just write a SQL query for me and dump this out into Excel?" So we're trying to avoid that. We're really trying to empower people so that they don't feel intimidated by the information.
Yeah, definitely a balancing act. I also have a question. Oh, it looks like we have a question from a member. How are the news stories chosen for the different analyst roles? Through AI or some other means?
Right now we work, certainly it's not AI right now. Maybe that's in the future. But we really just kind of work with the end users to determine what we put on the homepage and what analytics go on what roles homepages. So it's very configurable in the background. We have an end user representative will make what's going to be available for that end user, and then they can go and choose those reports. So we basically take a stab at it and say, hey, you're a health equity analyst, so you're interested in this sort of information, and we'll make that available, but we'll let folks know that they can choose from this, assortment of things based upon their security credentials that they have within the system.
Right, and maybe there's ways to see, click rates to see how often they're actually interacting with it too. Yeah. Another question: how are the targets set for incentive payments? Also, do the Medicaid managed care plans have a role in improving pregnancy outcomes?
Yeah, so that's I think a question for me. So let me take that. So the incentive payments, are again, we had a legislative mandate here in New Jersey, so there is a pool of funding that was available, and in addition to that, there are current reimbursements. So just to incentivize the providers. We work with, based on research, based on, some of the projected cost savings. We try to, establish some thresholds that would really promote the program and ensure that the providers are participating, and ensuring that they're being rewarded for the quality of work and for the risk they're taking on a go-forward basis. So again, it's based on existing funding and also current thresholds that they're currently qualify for, and providing a reward for taking the risks.
Great. Well, thank you, James and Samson. Next up, we are going to hear a presentation from Milliman.
Welcome and thank you for joining. I'm Nicole Zilliox, Director of Clinical Products from Milliman Medinsight, and I'm excited to explore how the Health Waste Calculator empowers meaningful change by driving value, impact, and equity in healthcare. As I'm sure you're well aware, rising healthcare costs in the United States are straining both individuals and the healthcare system, making care less accessible and increasing the financial burden on families and employers alike. Here you can see those rising costs year over year as data taken from the Milliman Medical Index. To address these rising costs, identifying and reducing wasteful spending and unnecessary services offers a powerful opportunity to relieve financial strain and enhance the efficiency of care delivery while maintaining quality. The Institute of Medicine, now the National Academy of Medicine, published their landmark study, Framework for Waste in Healthcare. They identified 6 categories of waste: unnecessary services, inefficiently delivered services, excess admin costs, prices that are too high, missed prevention opportunities, and fraud. The Health Waste Calculator supports 2 of these: unnecessary services at almost 30% of care, and inefficiently delivered services, almost 20% of unnecessary services. Imagine 2 similar patients with low back pain. One follows an evidence-based care pathway on the left there, while the other experiences a treatment journey filled with low-value care. As you can see, if we follow the evidence-based pathway, this patient who comes in with low back pain sees his provider. They recommend a 6 to 8 week course of physical therapy, and their pain may be relieved by the end of that. Now, if we follow on the right-hand side, that low-value care pathway, that similar patient with the same complaint of low back pain may see their provider, who then refers them for imaging studies, potentially a surgical consult, which results in surgery, which could potentially result in antibiotics, antibiotic-related infections, readmissions, and ultimately, after that whole pathway, still a 6 to 8 week course of physical therapy, while significantly more expensive and causing significantly more angst for that patient. Our measures are clinically nuanced, grounded in choosing wisely recommendations, and continuously updated to align with the latest guidelines, including those from the U.S. Preventative Services Task Force. Let me tell you a little bit more about our methodology. Our output empowers users to analyze cost savings potential by reducing unnecessary services, enhance quality and patient safety, and support value-based initiatives by identifying services to disincentivize making room for high-value care. The platform integrates comprehensive medical pharmaceutical claims with patient-level data available for deep insights. We also have the ability to incorporate EHR data, data from HIEs, as well as customized sources as well, including registries. Users can then create custom population sets with confidence thanks to Medinsight's data accuracy and standardization via our data confidence model and high trust certification. Seamlessly aggregating data from sources, Medinsight provides a collaborative, interoperable environment tailored to support public health reporting, health equity initiatives, price transparency, and quality improvement. More than half of all states have found value in the Health Waste Calculator. They've adopted the Health Waste Calculator as a standard for identifying service overuse, with published findings from states like Virginia, Washington, Maine, and Colorado, and RAND's analysis of Medicare fee-for-service. Washington has led initiatives like the First Do No Harm report and Drop the Pre-Op campaign to cut wasteful preoperative testing, while Oregon's Better Health for Oregonians report highlights further opportunities to reduce low-value care. I am so pleased to have one of our partners from Virginia offer her perspective on the value the Health Waste Calculator has brought her and her organization.
Greetings, conference attendees. My name is Beth Ports, and I'm the president and CEO of the Virginia Center for Health Innovation. I'm delighted today to get to just share briefly with you why we have been using Milliman Medinsight's Health Waste Calculator and how it has impacted our work in Virginia. We started using the tool in 2014 as one of the early adopters, and the nature of the data that the tool provided us was so compelling that in Virginia, we knew we had to form a statewide collaborative to take action. That collaborative became known as Smarter Care Virginia. It was funded by Arnold Ventures and included more than 1,000 practice sites, 7,000 clinicians at 6 health systems and 3 clinically integrated networks. The project continued throughout the pandemic, which was a difficult time for practices to engage in quality improvement, and yet they were compelled by the data that they were seeing, realizing that there was much that they could do to try to reduce the provision of the 9 low-value care tests and procedures they had selected. I will tell you that we have been through many iterations, many upgrades of the Health Waste Calculator. And one of the best things about it is that it does evolve and grow as more is learned about the quality of the data and choices in methodology. Today, we continue to put out annual reports on low-value care in the Commonwealth. If you're interested in seeing those, you can go to our website, that's vahealthinnovation.org, and check out Smarter Care Virginia. Again, I would just encourage you to check out the tool. It has been very helpful in Virginia. We were really surprised to see how much unnecessary and potentially harmful care was occurring in the Commonwealth, and we remain committed in Virginia to trying to reduce that using the Health Waste Calculator. Thank you all. Have a great conference. And if I can be of any help as you're exploring the tool, just let me know. Thanks so much. Bye-bye.
Always best from our clients. And in conclusion, I'd like to share an exclusive look at an innovative tool created to help you understand the impact of wasteful services in your most vulnerable communities. Participants of this conference can use the QR code to access our interactive tool, a reflection of our commitment to continuous improvement and innovation. Thank you for your time today.
Thank you, Nicole. I like the ending on the equity note. I think that's important to overlay over everything we do in healthcare. First of all, just as a general question, who does wasteful spending impact in healthcare?
Yeah, that's a great question. I think it really impacts everybody. You can point to, the patients, obviously, who have a patient responsibility spend, but also there's that element of patients are taking time off work to be able to have some of these procedures. And they're actually also losing credibility, losing trust in the healthcare system. If they go and have some time off, find potentially childcare, taking time off from work, have to pay potentially for, driving to these appointments. And then they find out, actually, there was nothing at the end of that. It was an incidental finding. So they really lose credibility. They lose trust in the healthcare system. Obviously, payers, those who are financing healthcare, they have an impact for wasteful services as well, especially when we define wasteful services as something that potentially is harmful for a patient and does not further that patient's healthcare journey in a beneficial way. And then providers, it really does touch providers as well, because we know that providers are really looking to service their patients. They want to deliver the best care possible. But when patients are losing their trust in the healthcare system, it makes it that much more difficult for providers to do their job and be able to create those trusting relationships with their patients as well. So I would say it really touches every aspect, every component of the healthcare, the stakeholders in healthcare.
Yeah, definitely. You mentioned, patients losing trust in the healthcare providers. I don't think most providers intentionally do things that are intending to be wasteful or trying to not resolve their patients' issues. So have you encountered any pushback from providers when they're kind of presented with their wasteful patterns?
Yeah, that's such a good question. I have a great anecdote where we actually were presenting some of the data, some of the findings from our health waste calculator, and we had a provider who said, "I know exactly, that choosing wisely, metric. I know that I am meeting that." And we were actually in the moment able to pull up his data and say, "Actually, we're finding that you are having wasteful services." And on doing a little bit more of a deeper dive, he found that it was embedded in an order set. So was he purposefully ordering this? He was not. However, that wasteful spending had still been embedded in his organization's policies, procedures. And so we were able to make real life impact. But to your point, providers sometimes are doing these things unintentionally because they're part of that process.
Yeah. So then once the waste has been identified, what then does it take to actually realize savings?
Yeah, really excellent question. And I'm going to bring it back to our first presenters with Civitas, with collaboration and building those trusting relationships. That really is so key. So building those trusting relationships, bringing those stakeholders to the table, having those open conversations and saying, we agree on our vision, we agree on the end goal, and how do we approach this, and leveraging data. Really, you have to have that credible, trusting data underlying it all to be able to move those effective conversations forward.
Yeah, definitely. There is a question. What is defined as necessary care versus wasteful services? Is this defined in clinical terms, or is this purely claims driven?
Yeah, so we leverage administrative claims to as underlying the foundation of our tool. However, the definitions and the methodology are evidence-based. So we use underlying that is the choosing wisely methodology, which if you're not as familiar with that, the professional organizations, physician organizations identified where were areas that wasteful services were being administered. And so our builds are entirely dependent on that clinical perspective. It is evidence-based 100% of the way. And we have clinicians who inform this, and we work with our partner organizations to ensure that there's credibility in our clinical perspective.
Great, thank you. I'd like to invite our other speakers to come back onto stage. And if there are any other questions for any of the presenters, please put them into the chat so we can ask our presenters. But I'd like to start just with a question for everybody around the role of transparency in data. So what role does transparency play in our data and our analytics and all we do to build trust among our users and that, our providers, our health agencies? So what role does transparency play in all of this? And I'll start with Jolie.
Sure. I mean, transparency, I think, having access to the most sort of robust, combined, enhanced data sets really allows us to have much greater insight into the picture, whether you're attempting to do whole person care, if you're trying to better sort of understand overall population management, those types of things. I think one of the things that is so important with transparency is your data quality. You have to know for sure that the data you're using is going to sort of pass muster, because if in any way you're sharing data with a group of providers or however that sort of might be happening, and you're doing anything, in and around public reporting, or if you are addressing low value care, like those types of things really matter that you've got the data right.
Yeah, definitely. James, do you have any thoughts?
Certainly, Jolie's right. I mean, and data quality is something that really at the base of it, we have been focused on for decades. but our clients expect to be able to get an aggregate report and drill down into that data to see the underlying claims or clinical data that are supporting those aggregate decisions. And then, the data governance schools are getting so good now that we can go back from from a table level back to the source files that make up the data pipeline to bring that data in. So the tools right now are just getting so good to enable that transparency. For those people that are able to use those tools, and it's just really making that transparency more available to the average user, so that people can gain trust in that. Because I think a lot of time is consumed, prove this value to me, prove this value to me, and it's really kind of incumbent on us to, as purveyors of health data systems, to bring more of those tools so people can prove those things to themselves, to the average user.
Great, thank you. Samson, anything to add?
Yeah, so in our case, for value-based, care with New Jersey, transparency was pivotal, because when you're trying to have a conversation with the practice where they're not meeting certain thresholds, or where they have questions around why they're not seeing some certain metrics being met in terms of quality, being able to provide the underlying data. And as James was alluding to, there's tooling available where you can actually do drill downs on these dashboards, so that you can grab the data real time and really provide visualization, so that the providers can grasp the underlying reasons as to why certain thresholds are not being met. And in my perspective, without transparency, programs like value-based care are difficult to implement.
Yeah, I think that goes back to some of the points from Jolie's presentation too, where if it's not local to you and you can't see what's feeding it, then you can dismiss it as not applicable, or not, you can't really do anything about it. Nicole, any last thoughts on transparency?
Yeah, I'll say, my colleagues on the panel here have really done a great job, but I would say specific to health waste calculator, we've seen that transparency with these states releasing the reports have really been instrumental to being able to impact change. And I'll just highlight that that's one of the underlying features of the health waste calculator is we're not a black box methodology. Once you license the tool, we give you that visibility, exactly what our methodology is. And one of the reasons is because you need that transparency to be able to communicate effectively with your stakeholders.
That's great. Thank you. Again, there's a question from the audience. Have you seen increases in wasteful spending in states that have implemented gold carding and prohibited step therapy?
That's a really great question. That isn't something that I've evaluated, but I'm going to definitely take that back. And we have a research team and something to investigate and evaluate. But I haven't anecdotally heard anything along those lines yet, but it's a really good question.
Thank you. Going back to equity and inclusivity impacts health data across the board. How can our data tools and our analytics ensure that we're incorporating things like inclusivity and equity and addressing disparities in the work that we're doing? And anyone can feel free to jump in.
I'm happy to start because I think we do have this tool. We directed you to that QR code, and I'm so excited to be able to share that first with attendees at this conference. There is a body of research that demonstrates that wasteful spending impacts vulnerable communities first and primarily. So having that opportunity to really understand where are those communities that are most impacted, who are those individuals, and then be able to take an aggregate action is really, really critical and being able to not just understand where are those vulnerabilities in the community, where are they accepting this burden, but also being able to really impact meaningful change.
And I think, not just Optum, but a lot of purveyors of tools across the healthcare ecosystem have also tools that they can bring in information on consumers. So if you don't necessarily have information where you can derive whether there's a housing risk or a financial risk from that data that may be in an eligibility system or another clinical system or a Z code or whatever. But incorporating risk markers from consumer data is something that we're seeing a lot done, so that you can bring in this consumer data and produce models on it. So there's models in consumer data that already exist. Certainly we as Optum have a number of models that we've run to enhance this data so that we get a better indication of social determinants of health. And then we can combine this with measures of clinical efficacy and value-based care, and so we can get a good profile of the risk that's associated with some of these populations. So we can map those things by geography, and then we can enable folks to do ID and strat on that to get to those clients who may not be able to get to a clinician, so they're overusing emergency services, for instance. So that's something that we're seeing as a trend, using different data sources from even outside the clinical data or claims data or eligibility data to identify social risk.
Great, thank you. I think we only have a few minutes left. There's an audience question. What metric is being used to identify the vulnerable communities? I think this is for Nicole, but.
Yeah, so we use the SVI on those 12 different indicators to identify what vulnerability was down to the zip code level. So if you are playing in that tool, you'll see that footnoted, but we did use that SVI to determine those factors of vulnerability.
Great. One last question. I know that AI is going to keep coming up because it's going to help us amplify the insights that we can generate, as well as help mine through some of the data that we have, healthcare or consumer or otherwise. Generative AI has a lot of exciting potentials, but it also needs a lot of guardrails to prevent things like hallucinations or disclosing information or that we don't want to, or building models based on biased data and training in that way. How do you envision a future of healthcare using and leveraging the potential of generative AI while protecting quality, safety, and everything else that comes along with that?
Well, I think people are being very careful, at least in healthcare. Like at least our company has a responsible use of AI commission, and we have to, prove out that our models aren't biased, in certain subpopulations, and I'm sure many other companies have, and governments are starting to get into that also. I think it's like guardedly optimistic, and people are starting to look at, okay, generative AI, what can we do here that has the lowest risk of harm? I think that's a responsible thing to do. So, obviously, as the data sets improve and as the models improve, we'll get better at it. But the important thing to know is that a lot of these models are trained on just the internet or Wikipedia or whatever. So any bias in that source is going to be incorporated in these models. So that's something we have to look out for.
Yeah, I would agree with James. I think a lot of companies are, especially in healthcare, are taking a step-by-step approach. I know Milliman's approach has been very conservative, and we have similar guardrails internally. Government structures and steering committees to ensure appropriate use and thoughtful development. I think one of the things that we've been thinking about is how do we ask better questions? And use AI, not necessarily we all also using it and developing the modeling, but also how are we thinking about using AI to ask better questions of the data as well, and not just get that data out of the models themselves.
Great. Well, I think we're at time. So I want to thank all of the presenters today and thank all the attendees for joining us today.
Thank you.
Thank you so much.